Good day, everyone. Welcome to Lippy Logic. My name is Dr. David Amron. You're at the Lippy Lounge, and today's topic is going to be the surgical treatment plan strategy. So it's very important to have a plan and to clearly define what that surgical treatment plan is. Every surgeon has a way of going about doing things and figuring things out and treating lipedema, but it's not just enough to say, let's just see how things go and do little bits and pieces. You want to, from the get-go, have a very clear plan. When I'm done with my consultations with patients, either in person or virtually, by the end of the consultation, I have a very clear treatment plan defined. What is being done, in what order, what is grouped together, what is the interval. At the end of that consultation, I explain it to the patients, and it's very, very clear. And rarely do I make a change in that plan because it's very systematic. The patient comes in the day before for the preoperative visit and it's confirmed, but again, that plan is defined very clearly. Like I mentioned in other segments, I look at the body from a standpoint of balance and proportion, which is a big discussion in and of itself in other segments. I also look at the body from a standpoint of cosmetic units. We've talked about that: calves and ankles, thighs, upper arms, torso. And I group these cosmetic units strategically in my plan in specific ways to go out doing the surgery. My goal is to always do a complete correction in the fewest number of surgeries possible. Typically, on average, that is 2 in the average lipedema patient. Rarely it is 1 and can go into a 3rd surgery in large, complicated patients. Very, very rarely do I ever go into anything more than a 3rd surgery, but typically it is 2 surgeries. And let me give you some examples of things. But first, I want to tell you that the limitation with each surgery is not simply only how much fat you're removing. As most of you know, the upper limit that has been defined is 5 liters by the American Society of Plastic Surgery and Derm Surgery as a guideline. I will say that 5 to 6 liters is the average I remove in every patient. I commonly remove more than that, 7, 8, 9 liters, up to 12 liters with my specialized technique. And that's a whole other discussion in terms of that and why I know it is safe. But it's not only just the limit of the amount of fat that you're removing. One of the main limits is the surface area that is being done with each surgery. And there is an absolute limit with that I never exceed. And that limit has to do with lidocaine levels. Because if you go past safe lidocaine levels with your local anesthesia, you can get into unsafe areas. And the limit that I keep within is under 55 milligrams per kilogram of body weight in every patient. You do not want to exceed that. So it's a calculation in terms of the surface area that can be done. And that's why things are grouped in specific ways. So also 95% of patients that we've talked about are done circumferentially, all the way around. Only about 5% or less are done semi-circumferentially, and that actually is a specific treatment plan strategy that's put in place in those patients. But to give you some examples of things and how I go about doing these and grouping things, in your average patient, let's say it's a stage 2 or stage 3 patient that has involvement of their entire leg unit circumferentially, all the way from the outer buttock area all the way down to the ankle area, which wraps around. You start to get that column-like look to the legs. Most of those patients are going to have involvement of their upper arms, and many times the forearms will begin to get involved also. Those patients are done as a 2 full surgery plan, and they're done completely in those 2 surgeries, and the grouping is this way. The calves and ankles as a unit are done from the knee all the way around the back to what we call the popliteal fossa, that line around the back of the knee, down to the ankle area, circumferentially. And with that, I will generally group the upper arms, and if the forearms are involved, those are done along with that too. It is impossible to do the entire thigh unit and calves and ankles circumferentially the way I go about doing it because of passing the safe limit of lidocaine levels, which is 55 milligrams per kilogram body weight. So that type of patient, stage 2, stage 3 patient, arms, legs are involved, will be done as 2 surgeries. Calves, ankles, arms are done as 1 full surgery, and the circumferential thigh unit from the knee all the way up to the groin area as it wraps around the outer buttock area, underneath the buttock, the whole back part of the thigh is wrapped around circumferentially as another full surgery. Both of those full surgeries are done as separate trips to Los Angeles, a month or more apart between the surgeries as the interval. If a patient has involvement of the upper buttock area called the pelvic girdle as it wraps around to the lower abdominal area and it's just involved there, that involves what I call a half a surgery. I know it's always saying half a surgery, what does that mean? But in my world, it's a half a surgery because of the surface area that's involved in things. And in that 2.5 surgery plan, the grouping may be this way. The calves and ankles are done as in the first surgery with the upper buttock area because I want to decongest that area proximally along with the calves and ankles as a full surgery. The other full surgery is a circumferential thigh unit from the groin down to the knee, wrapped around. That's going to take a person through one complete circumferential surgery. And the arms become, again, a half a surgery, a smaller area. Sometimes I will group things a little bit differently and do the calves and ankles with the upper arms and the pelvic girdle as its own area as a half a surgery. The two main surgeries are done a month or more apart at separate trips to Los Angeles, where a patient is here between 4 and 5 days. We're going to talk about this in the consultation process at another time, go into more detail about that part of things. And the half of surgeries can be done 2 days apart from main surgery and grouped with it, or it can be done separately later on as a separate trip to Los Angeles. If it is involving, rarely in patients, a circumferential torso, and that entire torso area is involved in lipedema, and it can be in some patients. It's not only just the pelvic girdle. It can involve the central and upper abdomen, and even in the back in some patients, or just for cosmetic reasons, that everything needs to be blended in. A person has fullness in those areas, and we do the circumferential torso unit as a unit. That is a full surgery. And so rarely, if a person is literally getting their entire body done, calves and ankles, thighs, full torso, including hips, upper buttocks, arms, forearms, it's generally a full 3 surgery plan, but the average patient is a 2 surgery plan. Again, a lot of information, hopefully that made things clearer for you. My name is Dr. David Amron of Lippy Logic. Thank you for tuning into the Lippy Lounge.